Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullah. Thanks to all of you who are present here. We'll just start off with the workup that we need to go through. And most of the stuff is very clear. And I think there's certain gray areas that we would like to just touch upon. So the goals, as is very clear to everyone, is to get a standardized workup, especially for our patients who may sometimes present a dilemma. And then early diagnosis is key for all medical problems that we know. So it'd be good to have a scheme in our mind and perhaps a standardized protocol or the pathway for our patient's journey. There's so many different conditions which are classified as ILD, interstitial lung disease, and we've gone through quite a few of them. Whether this is acute or subacute or chronic, that is a good distinction to be had in your mind before we move on. And also to know the triggers for certain conditions, because certain conditions may have a trigger that we can modify and things would be a lot easier to then move on. And there are certain cellular or reversible and irreversible or fibrotic conditions. And then knowing whether progressive diseases are being dealt with or the other conditions. And there are quite a lot of conditions that we deal with, and that is not the part of our discussion today. So one has to be very clear that these are other differentials that we would like to make sure that we're not missing out on. And then focusing on our interstitial lung disease, which is the talk for today. We've already heard that there is a spectrum of inflammation, which is cellular component to the fibrotic element, and something in between. So one has to have that very clearly in their mind. Now, UIP, for example, for those who are non-respiratory here, they should know that UIP does not equate IPF anymore, and people are very clear on this. So when you see a patient and you suspect interstitial lung disease, after history and examination, as we've gone through with Professor before me, a chest X-ray is the key. Once we've had that, we just try to look whether there is alternative diagnosis or interstitial or idiopathic lung disease. And high-resolution CT scan, serology, and full lung function tests, including diffusion capacity, will be the key. And MDT is the mainstay. Without multidisciplinary team, we cannot diagnose, and we shouldn't diagnose. I mean, take it as as we used to do with cancer, and we always diagnose lung cancer or any other cancer in MDT. So should be ILD. No one should think that they can manage without having a radiologist on board, a pathologist, if possible, or at least in difficult cases. But a rheumatologist would be a very, great, luck to have one, but it'd be very, very useful. MDT, as I said, is the key. Now, what are the tests we're going to do? Routine screening tests are generally not diagnostic in any way, but they're done in order to exclude other problems, other conditions, which I showed in the first slide about alternatives. There are certain serological markers, especially for connective tissue disorders. We heard in our case in the beginning that how it is going on a very, increasing day by day with regards to our incidence and prevalence, connective tissue disorder presenting as ILD. So you would just do as a routine in our center, for example, we just get ANA and rheumatoid factor or anti-CCP, as opposed to all the battery. If any of that is positive, then we move on to get the panel, depending on which side we're going to. Obviously, if there was clinical signs, then yes, but we should know that ILD may proceed in a good number of patients, and you may need to just repeat your autoimmune profile, your myositis panel, or your, in order to make sure that they are not now manifesting the rheumatological condition. So you can't just be thinking, I did it 5 years ago and it was negative, and that might not be the case. You have to keep repeating it if you suspect, especially with anti-synthetase syndrome, as we know, is quite common. And these patients, especially with anti-synthetase syndrome, ANA may still be negative. I just had a patient who we ended up having to give cyclophosphamide and rituximab after initial pulse methylprednisolone. We ended up sending her back to Brompton Hospital as a tertiary center. And finally, after the third time in 3 months, we got a positive result and it's antisynthesis now. So keep that in mind. It's not day-to-day occurrence, but it's quite a thing to be kept in your mind. Hypersensitivity pneumonitis, as we know, there's certain triggers that you need to identify. Sometimes history might not be very clear. Sometimes patients do not think the value of that particular history, a piece of history. We keep revising it, keep revisiting it, and we get somewhere. And then depending on what we find, we move on, and we'll hear about that from Dr. Saima in CTD-related ILD. Pulmonary hemorrhage, it might be quite useful to have some other markers to be done, anti-GBM, as we know, and ANCAs. These tests, like CRP and ESR, hypergammaglobulinemia, these tend to be raised and high, but have not got much value with regards to diagnosing. Rather, they're there to exclude other potentials so that we do not miss out on the other potentially treatable condition and not mislabel them as ILD. There's certain research tool, we might hear about them in future, but at the moment, they're not recommended. There is this KL6, which is specifically associated with certain ILD, and it has got high sensitivity. At the moment, it is just as a research tool we're using, but not for practical use. Radiology, chest X-ray, and the high-resolution CT scan we discussed, and we had a detailed talk on. That's a mainstay. With regards to the lung function test, we know there's restrictive defect you would see, and it has diagnostic plus prognostic value as well. And that is why we serially monitor these patients with their spirometry and diffusion capacity. And those are the most important two sides of full lung function test. Now, there's a trend, and there's a lot more discussion on having a handheld spirometer to be given to the patients at home to be monitored themselves, ideally once a week if possible, and then keep updating the physicians whether there is something that can be done. Now, there may be obstructive picture as well, especially in LAM, sarcoid, which can sometimes affect you in the bronchial tree as well. And COPD could be coexisting in these patients, especially with smoking history. So a third of patients may have a coexistent obstructive pattern. 6-minute walk test is something that we do quite regularly in order to unravel some of the subclinical hypoxemia in these patients. And it's quite useful, especially if the heart rate recovery time is more than 1 to 2 minutes. That sometimes suggests that there is something underlying going on, although you might not pick that up in the initial full lung function test. Then coming to bronchoscopy, a lavage is extremely important in excluding infection, especially TB, for example, and other chronic infections if they've been unwell for some time. And hemorrhage, pulmonary hemorrhage could be diagnosed with that. So it's quite a useful tool. We tend to do that, especially where there is a suspicion of cellular versus fibrotic HP, for example, because the prognosis is significantly different. And now also this concept of UIP versus non-UIP, regardless of the underlying cause, regardless of whether it is due to connective tissue disorder or IPF or HP, chronic HP, UIP pattern on its own is the worst ever prognostic marker for these patients. So we would like to, if there was any shadow of doubt about having some ground glass changes, we would like to do a valve to look for lymphocytosis. So normally, lymphocyte count above 30% is quite useful. So we normally, anything above 20%, we take it a little bit serious and then try to offer them immunosuppression. Otherwise, you may just end up not offering much and then labeling them more fibrotic than cellular. So obviously, for compared to IPF, before you label it as IPF, it'd be good to just have that done. The few uncommon condition, but may have some diagnostic value for bronchoalveolar lavage, alveolar proteinosis, as we know, you get a milky fluid coming out. And for sarcoid, we would have a discussion about that, especially with the high risk and high ratio of CD4 to CD8 count. That could be useful. Pulmonary hemorrhage wise, cancer, infection you can diagnose as well. It's a useful tool. We still do that quite a lot in our center, unless radiologically we are in the definitive or most probable IPF category, which we'll hear about later on today. Cryobiopsy is getting much more of a tool that perhaps in very near future be the mainstay with the low risk of bleeding complication, but also to get the tissue diagnosis. And it has got quite promising results, especially on these two trials recently done, cold ice and can ice. They both prove that they're as good as your standard surgical lung biopsy. So there's a lot of discussion, obviously, but there's no standardization as to how much to freeze and how long to carry on and how, which areas and how many samples you have to take. There's still a work in progress, but I think this is something, as I mentioned, UIP pattern is something one would like to establish in your patients before we, wash our hands thinking that they're on the palliative route or more antifibrotic route. If I'm not misheard, we haven't got antifibrotic here yet, or do we? We have it. Both of them. Only pirfenidone, which is going out of favor now. More nintedanib, isn't it? That classified something, again, there's some talks about it, but it's not out yet, not recommended yet, but very good for UIP pattern, RNA sequence. If you get that, I don't think it's going to be available in the next few years, but keep that in mind as something coming up in future. Raghu mentioned that in his paper as well. Open lung biopsy or VATS biopsy is something you might want to consider after the MDT discussion. We're still not sure whether this is UIP or not. But you try to avoid it as much as possible. And it's actually considered to be a bad practice to offer any surgical intervention to patients who radiologically you can diagnose UIP pattern, because the complication and the risk, even trigger of the acute exacerbation is quite high with surgical intervention. I would like to not harm the patient as our first. Coming on to some acute exacerbation. So what would you do in those patients? So chest X-ray again, because many a time it doesn't have to be acute exacerbation of ILD. Rather, there could be other possibilities. Looking at pneumothorax, we saw a case of possible LCH, pleural effusion, pneumonia, cancer as well. There's high risk of cancer, as you know, with ILD. And heart failure, valvular disease, copulmonale, doing CT angiography to look at the disease, but also PEs, because these patients tend to be a bit more sedentary, more housebound or practically housebound. So they may end up having PEs. And likewise, other viral illnesses that might show up as haziness on the X-ray or the CT scan. One would like to make sure that we have not miss out the opportunity of treating the treatables in these patients. And then obviously plus minus bronchoscopy if there was a concern. How often get this scan? Then no clear-cut guideline on that, but it all depends on your clinical judgment with these patients. So we normally try to review those patients, especially if they're on immunosuppression, every 3 months to 6 months time, depending on how stable they are. Obviously, with the mycophenolate and azathioprine, they have to have their regular monitoring. So we have got a collaboration with our community team, the GPs mainly. So they do the blood tests initially, the weekly, and then fortnightly, and then monthly, and then we keep reviewing them. Our nurse specialists, ILD nurse specialists, would then monitor these patients either 3 monthly and we see 6 monthly. So there's a collaboration. How often do you do the CT scan? Only based on your clinical judgment. If someone is steady and very much doing quite well on their medication, and if they're not on significant immunosuppression, so you would like to make sure that there's no failure, or the success rate, depending on which way you were going. It's important to do maybe on a yearly basis But again, that should be discussed in MDT, looking at the patient's parameters, lung function test initially. If there was a decline, as you would hear possibly in your IPF talk, about 10% decline is a significant decline, you would like to exclude the possibility. At that point, you should have your CT scan repeated. That's a must. If there was 10% or more decline in FVC, and likewise on DLC or either of those, one would like to make sure that we've not got onto this progressive interstitial lung disease, which we should be very careful about. And looking at comorbidities, as I already mentioned, was just making sure that we do all the right thing for these patients. And UIP pattern, I already alluded to, the fact that it is single converging line where we head off if we identify in our patient, regardless of underlying cause, and that's a poor prognostic marker. So one would like to early diagnose and then refer the patient straight onto antifibrotic if possible, and they can tolerate it. The final point on this disease progression. So if they're doing it and they're not showing so much of a effect on the clinical and symptom wise, then we need to think about this progressive fibrosing interstitial lung disease, which we already heard about. That this is a group of different conditions of ILD leading up to this progression without moving at all, really, with all your armamentarium, whatever different medications you've tried. And this is really about quarter to a third of your patients might end up being on that case. That is why they say if you diagnose it early, then it's good news. You can refer for all the antifibrotics or immunosuppression rather than delaying. So if you do not get a clear diagnosis and the patient has not been established on their immunosuppression within 6 months to a year, then they would end up being in that category of progressive pulmonary fibrosis. Are we talking about non-IPF patients here? All of this is about non-IPF because IPF is a separate talk. So with that, I would just like to say that this is your summary. You normally investigate as you would go along. And if there was any clinical deterioration, you would like to make sure, or you want to come off your medication, the immunosuppression, then you would revisit them with X-rays, with lung function and CT scan. With that, I come to the end. Thank you.